Hi, hello, this is Dr. Kai, and welcome to another case from the interesting world of imaging in rheumatology. So, today I have with me a case of a lady with problems of the peripheral joints, and we will analyze images together with the clinical picture to see if we have one diagnosis or we have two diagnoses or even three. So let's dive in. So here you see the medical history of this lady. We can learn that this is already 87-year-old woman. She currently has swelling of the entire right hand. There's significant morning stiffness, that means 60 minutes and more. And she also has arthralgia in the DIP joints and the wrist joints. On her anamnesis, we did check for collagenoses and vasculitis, SPA manifestations, chronic inflammatory bowel disease, uveitis, psoriasis, and any sorts of infections, and all of those turned out negative. So there was a previously diagnosed rheumatoid arthritis, and we will check her images shortly. Before we do so, we will also look at the lab results. You can see that CRP is normal, the differential blood count is normal, liver enzymes normal. There is some kidney problem with the pathological GFR, and she has no rheumatoid factor, but she has positive evidence of ACPA antibodies, and all other autoantibodies are negative. So let's have a look at her X-rays. So usually we start with analyzing X-rays of hand and feet, and it's always advisable to have both sides on one screen and compare them together. So here we have the right and the left hand, and if we look at the DIP joints, we see clearly there are some osteophytes over here. We have malalignment, we have joint space narrowing, especially at the second and the third ray. On the right side, the second ray is not so much affected, but the third one is. And we also see similarly osteophytes here at the PIP joints, here in conjunction with some cystic subchondral lesion in the base of the middle phalanx. So these are very compatible with osteoarthritis. We see some calcifications over here close to the joint, also here. So this could raise some suspicion of CPPD, but also in osteoarthritis, sometimes we see these kind of calcifications in the capsule that we are calling metaplastic calcifications. Looking at the MCP joints, we, of course, knowing that she was previously diagnosed with rheumatoid arthritis, would search for erosions because these are the typical joints. For this, we can see that the joint spaces are rather narrow. So this could be due to pre-existing arthritis. I mean, the joint space is uniformly decreased, but it would usually be double the size in an unaffected individual, maybe. And here on the right side, you can even see that there's concentric joint space narrowing. That means it's more likely to be associated with osteoarthritis than with rheumatoid arthritis. It's very unclear if there are erosions here, so I don't see any larger erosions at the MCP joints. Maybe we can see some lucency here. This cortical line should usually go all the way here, and there is some lucency here. If you compare it with the other side, the cortex usually has a very smooth and continuous appearance, which is not the case over here. And also here we have some cystic lesions in the head of the left metacarpal, which gives us some suspicion for erosion. Looking at the wrist, we can see that there is some osteoarthritis of the CMC1, but also the STT joint. Radiocarpal joint has quite some good joint space on the left side. On the right side, we similarly see joint space narrowing and subchondral sclerosis with good delineation of the radiocarpal joint. And in addition, we see also very intense calcification of the TFCC on both sides, and this extends here to the ligamentous structures close to the CMC joints, STT joint, and maybe also some intercarpal joints. So we have calcifications, we have joint space narrowing, and we have osteophytes. So this would be a good example of osteoarthritis and also a concomitant CPPD. Looking at the feet, we see a different pattern. The right foot is showing here, the left foot is showing here, and what you can see is cross destruction of the head of the metatarsal, of the base of the proximal phalanx, this luxation. It's no longer subluxation, it's luxation. Also here we see erosive disease, we see erosion on the lateral side. So there are symmetric appearance of erosions in the MTP joints on the fifth ray, and we also see destruction here in the MTP joint 1 with large defects in the middle, in the basal phalanx, in the head of the metatarsal. Also here, so large erosions, and there are also some erosions visible here in the third MTP joint. If you compare to the fourth one and the second one, you can see there are some cystic lesions over here. So what else can we see? There are some faint calcification, but actually they are not so faint. They are quite obvious. And also here we see calcification. So this could be a manifestation of gout, but also of CPPD, which again goes in line with the changes that we have seen in the wrist. Okay, but the patient had a very severe swelling of the entire right hand. So we pursued advanced diagnostics, and we performed an MRI of the hand. And here I can show you the images. So this is the T1 weighted image. We can see there are, of course, as we expected, there are osteophytes and joint space narrowing in the DIP joints and PIP joints. There's a little bit of capsular thickening over here in the PIP joints. And then we also see synovial hypertrophy in the MCP joints, and there's subluxation over here. And we might also see some erosive defects in the MCP joint on the second ray. If you compare it here with the fluid sensitive sequence, we can see there is some bone marrow edema in some of the bones, definitely here in the base of the basal phalanx. There is some bone marrow edema also in some wrist bones, and we have some intense, very intense bone marrow edema over here. And we have also synovial hypertrophy in the distal radioulnar joint, close to the styloid process of the ulna, and also in the radiocarpal joint and in other joints. In order to distinguish or to depict it in more detail, we always use a wipe sequence, which is a sequence, as you can see it, with 0.8 millimeters. So we have a very good three-dimensional representation of the hand, and this gives us the option that we can zoom in and see what's going on in these small joints. So that if you do regular fast spin echo sequences with about 2.5 millimeter slice thickness, that's usually not justified. You need thinner slices, and here we see the erosive changes in the basal phalanx of the in the base of the basal phalanx, and also in the head of the metacarpal, and this also keeps true for some of the other bones over here. Going further to the axial slices. Axial slices are always very informative, because it's very easy to see synovitis. We see it here extending in the dorsal aspect of the fourth MTP joint. In the volar aspect, we can see that there is some synovitis also here, and we can also see the destruction in these joints. So in total, we have now evidence of erosions that we were not so sure based on the X-rays. So we also see a lot of synovitis in joints that are a typical location for rheumatoid arthritis. That is the interphalangeal joint. These are the MCP joints. These are the radiocarpal joints with also some effusion over here. So in total, we see a mixture of X-ray related changes, and that is joint space narrowing, osteophytes, and calcifications, but not so much erosions. In the feet, we have clear erosions. We have a typical pattern with involvement of the fifth MTP joint. Also the fifth one is very typical. First one can also be affected by other diseases, like for instance gout or osteoarthritis. And we have this mutilation that is very typical for rheumatoid arthritis, and also capsular calcifications that we could see on the X-ray. On MRI, however, osteophytes and joint space narrowing is prevalent in the DIP and PRP joints, but also synovial proliferation and synovitis is the dominant finding in the PRP joints and MCP joints in the wrist. And also we found some erosions. So our total conclusion here for this patient is that she had 3 diagnoses. She has an established rheumatoid arthritis with already late changes, but this disease is still not inactive. We still have active disease that warrants anti-inflammatory treatment. We have osteoarthritis that is affecting other joints than the rheumatoid arthritis. So it's not on the same joints in most of the instances. And we have calcium pyrophosphate deposition disease, CPPD. And this CPPD can occur as a primary disease, but in patients with RA and also OA, it sometimes occurs as a secondary feature due to the long-standing inflammation. So what can we learn? We learn that we need to take care about the joints, that we need to be very specific about the clinical examination. If the patient has a swollen hand and is very old and there are osteophytes in the hand, still this patient is not automatically just degeneration. It could be still active rheumatoid arthritis, and we could nicely show this with our MRI investigation. And we started treatment that was targeting rheumatoid arthritis, and after a while her symptoms decreased and she went better. So I hope you would have done it the same, and I hope you learned a little bit about what we do on a regular basis to care for our patients with rheumatic inflammatory diseases. And sometimes it's not so easy as in the textbooks, as patients have more than one diagnosis. Thanks for watching, and see you in the next video. Bye bye.